Hello, I'm Dr. Maureen Markman from City of Hope, and I'd like to continue with the discussion we started in the last session with some provocative abstracts that were not drug-related presented at ASCO 2025. In this session, I would like to briefly discuss a very important abstract. Be interested in seeing the final paper when it is published in peer-reviewed literature in dealing with the question of primary surgical cytoreduction in advanced ovarian cancer versus a neoadjuvant approach, followed by interval surgical cytoreduction and perhaps additional chemotherapy. This has been a hotly debated topic in the area of gynecologic malignancies for well over a decade. And in fact, there have been several phase 3 randomized trials reported to date, published in the peer-reviewed literature, that have demonstrated fairly convincingly, in my opinion, that either approach is acceptable with no difference overall in survival, and some of the trials suggest that possibly even an advantage with a neoadjuvant approach as relates to post-operative morbidity and mortality, meaning if you treat a patient aggressively with surgery, there could be negative outcome in terms of surgical outcomes, whereas the neoadjuvant approach may allow a patient to potentially undergo surgery later with less morbidity and mortality. Now, this has been a very controversial discussion because there are surgeons that would say, yeah, but not in my experience. If I did the operation or at my institution, we would not have that morbidity. And we believe, based upon our own data, outcomes will be superior. And therefore, this particular trial that we're discussing here becomes very important. Trial is entitled TRUST, Trial of Radical Upfront Surgical Therapy in Advanced Ovarian Cancer. And we're seeing here, again, abstract form, are the results of the studies. So randomized phase 3 trial, they'll look at patients with stage 3B or stage 4B ovarian cancer with a good performance status, ECOG 0 or 1. It compared 3 cycles of neoadjuvant chemotherapy, followed by interval surgical cytoreduction, then 3 additional cycles of chemotherapy versus primary surgical cytoreduction, followed by 6 cycles of standard chemotherapy. Maintenance of bevacizumab or PARP therapy was permitted, as stated in the abstract. Very importantly, this trial included, as discussed in the abstract, very careful overview of the quality of surgical management, which included experience with a sufficient number of cases so that the lead investigators could ensure that the surgeons participating in this trial were of the quality that they defined as necessary. Overall survival was the primary outcome of the study, as it should be in this situation. We are talking about aggressive surgery versus not such aggressive surgery. The question is, do you improve survival? There were 688 patients participated in this trial. Not surprisingly, 91% had high-grade serous histology. Complete resection was to no gross residual disease, occurred in 61% of the patients who underwent the primary surgical cytoreductive approach versus a little over 75% in individuals who had the neoadjuvant chemotherapy and then the interval cytoreductive surgery after 3 cycles of chemotherapy. As reported by others, if you obviously give the chemotherapy first and you operate, there'll be a higher percentage of patients who will have be able to be at the end of that surgery, after 3 cycles of chemotherapy and surgery, high percentage of patients will have no visible residual disease. The bottom line here was, if you look at median progression-free survival, it was 22.2 2 months in the patients undergoing primary surgery, 19.7 months in the patients who had neoadjuvant chemotherapy followed by surgery. But the bottom line, primary outcome in the study, median overall survival was 54.3 months in the patients undergoing primary surgery, 48.3 months in patients who had the neoadjuvant chemotherapy followed by interval surgical cytoreduction, p-value of 0.24, no statistically significant difference in the outcome of the patients who received primary surgical cytoreduction by a group of surgeons who are very well experienced and known to be able to do aggressive and safe surgery. No difference in overall survival compared to the patients who had the same surgeons, but they had a neoadjuvant approach. Importantly, and as predicted, the 30-day postoperative mortality was less than 1% in both patient groups, and the morbidity was stated to be acceptable. I read the conclusion of the abstract by the investigators because I wish to comment on that conclusion and present my own conclusion based on the data. So, as stated in the abstract, in expert centers with proven surgical quality, primary cytoreductive surgery followed by IV chemotherapy results in significantly longer median progression-free survival and numerically longer overall survival compared to neoadjuvant chemotherapy interval cytoreductive surgery in non-frail ovarian cancer patients. Although statistical significance in the primary endpoint was not reached, this is the first randomized trial to show a benefit of primary cytoreductive surgery over interval cytoreductive surgery. So my conclusion is primary cytoreductive surgery is a very reasonable approach if it can be undertaken by surgeons with excellent experience at centers with similar experience, and that there is no disadvantage of this approach if undertaken in this setting with due consideration to the potential morbidity and mortality as relates to both the extent of disease and patient comorbidities. However, neoadjuvant chemotherapy in the same patient population is also a very reasonable approach with similar overall survival outcomes if primary cytoreductive surgery is not felt to be in the patient's best interest. There is no overall survival advantage either in this abstract or other studies that have been examined this particular question in well-designed phase 3 randomized trials. Again, primary surgery is a very reasonable approach if undertaken in appropriate settings, but there is no need to be overly aggressive with the idea that somehow if a surgeon undertook a very aggressive procedure, that gives the patient the best chance if there are reasons to be concerned based on the extent of disease or underlying patient comorbidities. And I thank you for your attention.